Okay. Yeah, 7 French is okay with the radial, especially if the artery is big.
There's a lot of debate, prior to the case whether you should pre-dilate this diagonal or not. Especially from the French experience, they would be very aggressive about not pre-dilating. It's sort of only if there's diminished flow after the pre-dilatation consider pre-dilating the diag. I think that's always one of the discussion points that comes up, and I think it's difficult to have an absolute right answer for any of these scenarios.
So this audio is not very good, but what I heard was that we are trying to understand whether we should pre-dilate the diagonal here or not.
Yeah.
And
go. Hello, Coral. I think Marty's mic and my mic is working all right. I think
Marty's audio is good. Sushil's audio has an issue.
Yeah.
I'll just keep quiet. That's their way of telling me to keep quiet.
That's all right.
Okay, I think this is important, how easy it is to wire the diagonal. Because certainly if it's difficult to wire the diagonal, then it will be important to make sure that you pre-dilate the diagonal. So for Srinivas, not so difficult.
We are very fortunate. So the wire is also worried about you, maybe. It's getting wired faster. So entry point, we do that, and then the distal portion, as you all do, probably it went into your branch. We'll come back and then...
went into a branch. He'll redirect it into the main portion of the diagonal.
With the branch itself, there's decrease in flow.
Yeah, just putting the wire down, now the branch has less than TIMI3 flow.
I think
you can see.
So do you use, I have a question, do you use a specific technique or an understanding where you avoid twining of these wires when you advance them?
Yeah, I'll just let you know once I just wire it. We have some indigenized technique basically to avoid intertwining. What we put here, can you focus here? This is actually very primitive, looks very primitive. That's how we avoid intertwining of wire. Can you see this here? Can you see can you project here? So this is actually, we just put a normal gauze, and if you put it back, then the LED wire is down, and if you want to work on the LED, you put it back on this side.
We can't see what you are showing, so the camera has to show this.
Can you project here? We just put a small gauze piece in between these two wires.
Yeah, okay.
Okay, that's, I think many centers do practice it. When you do it this way, the diagonal wire is below and the LED wire is on. When you want to work on the diagonal, you turn that side. So it's only diagonal.
We all use this technique, but I actually tend to avoid the gauge pieces because unless it is lint free, because sometimes the lint tends to stick to the wire and makes your balloon movements a little difficult.
Yeah,
what do you think, Anil?
Yeah, if you're comfortable, anything, I think you can use.
There is actually a device in the United States that Paul Tierstein has developed to help seat the wires. I don't think it matters when you have 2 wires, but there are cases where we have 3 and 4 wires, where it may be helpful. And we do the same technique, but we'll do it with a towel.
Yeah. So now we take a balloon. What size balloon you would think? Diagonal?
Yeah, I think in this case, just putting the wire in the diagonal caused reduced flow, so I think I would pre-dilate the diagonal. Yeah.
Would anyone on the panel not pre-dilate this diagonal and just dilate the LED and see how the diag reacts?
We couldn't hear him well, but I think he was asking
Sushil, what he's asking is whether anyone in the panel wouldn't like to dilate and put a work only on the LED?
What do you think?
We actually have not seen the images, but we hear you that the flow is reduced in the diagonal.
Yeah.
If the flow has reduced in the diagonal, then you have to balloon it.
Anil, we'll take a picture for you.
Yeah.
Yeah. What about an RAO cranial view, a steep RAO cranial? Would that be a better view to look at the bifurcation in this patient, or this is the best view?
Yeah, I do think either the AP cranial or the RAO cranial might be a little bit nicer to look at, yes. In this case, maybe the AP is even better.
Yeah. Let's try AP.
Well, that was a very steep RAO cranial that you had before. RAO 41, cranial 46. Okay? Yeah, but that was very steep.
Yeah, so it would be fair to pre-dilate this diagonal.
Okay. We have taken 2 into 12 mini-truck balloon to dilate the side branch.
So it's always good to predict. Do you think that this is going to require a second stent in the diagonal?
Yeah, probably if you're pre-dilating with a balloon, there's more chance of producing dissection, but we'll try to do a low pressure dilatation and try to see whether we can avoid dissection. The balloon went actually pretty easily into the diagonal. Maybe that again we could.
The choice of a 2.0 balloon is clearly undersized for the diag. Is that trying to minimize
minimize the risk of dissection. We'll just check once. I think that's okay. Go. Low pressure.
I'm not sure if they can see or hear.
Okay. Are you able to see the image as well?
Yes, we can.
Okay. That's it. Done. Small test. Small test. Integer picture. I think that's better.
Okay.
That responded very nicely.
Yeah. Just to save the cost, we tend to do little under dilatation to the main vessel and use the same balloon to dilate LED, though I'd agree that you need to take a little bigger balloon for the LED. Because it's a live case, we can as well take a bigger balloon here, but in general practice, we try to use little low undersized balloon, balloon, so we can cut down on the cost.
Yeah.
2.5, we'll take it for diagonal LED.
Sure.
Yeah, I think a 2.5 for pre-dilatation is fine for the LED, yes.
Goes. That's what he said. Yeah. How many of you feel that you will end up with a second stent, putting a second stent in the diagonal?
Well, now that you have pre-dilated the diagonal ostium, there is a good chance that you're likely to use 2 stents.
So would you have not pre-dilated the diagonal ostium?
If you wanted to get away with 1 stent, maybe you could have tried not dilating the diagonal ostium and just keeping the wire there as a KIO, keep it open.
Frankly, that was our plan before we started, but once we wired it, we thought the flow has come down, then we changed.
But Anil, there is a pre-existing disease and that appears to be significant in the diagonal branch. I think you need to pre-dilate because otherwise the risk of occlusion is even higher. Don't you think so?
But there's a possibility you'll get into a dissection.
He's got to turn his head.
Yeah. Okay. Small test.
I mean, I think your discussion illustrates the controversy. Some people feel very strongly one way and the other.
This is just a 2.5 balloon in the LAD. It's a very soft lesion, very eccentric plaque, which you see well in some of these AP views.
So Dr. Martin Leon, would you use an IVUS in this patient in all your cases?
You know, that's a very good question. I think that everybody is sensitive to cost. When we treat LADs, we usually use IVUS. I like understanding more about plaque composition, plaque length, vessel size, because my philosophy is I have to get a perfect result when I work in the LAD. I have to be as good as a surgeon who does a lima. So in a case like this, to understand more, I would treat with IVUS, and I would also make sure that the expansion is perfect with IVUS after the procedure. But I respect the fact that there are some cost issues associated with IVUS, and this is a fairly straightforward lesion, so it's hard for me to argue aggressively that you need IVUS for all of these cases.
I mean, cost, I think, is one of the main issues in terms of IVUS penetration in outside the U.S. and Japan, right?
I think it's cost, and I think that many people, I think you could see a nice dissection right at the bifurcation here.
Yeah.
You see it
it is in the LAD?
It's in the LAD, yes. It's not in the diagonal. This was a very eccentric plaque, so I'm not surprised.
Yeah, we'll take a RO cranial view to see the length of the stent which we take, because it's opened up very well there.
Is that projecting there well? Can you guys see the dissection?
So Dr. Leon, if you understand the lesion anatomically on angiography as well as IVUS, so what would be your expected length of a stent if you're not using IVUS and just looking at the angiography in this patient?
So my expected length of the stent here, I would go probably would stent to, I mean, here you'd have to make a decision. Do you want to stent to that large septal branch, or do you want to go, there's a bend point in the LAD just beyond that septal branch?
Right.
The disease extends beyond the septal.
We can see the disease extends beyond the septal.
Yeah, so I would probably work to that bend point in the LAD beyond the septal, is where I would start distally, and then I'd come back to where the shelf is. Now that's going to be a fair length stent. So that
looks like a 32 or a 28 minimum, is that right?
Maybe, I think it may be a 24.
Yeah, you just, can you just do QCA once? 24 balloon. 24 balloon.
I will take Endeavor Resolute 24. Would people,
must be a
this dissection in the...
24, yeah.
You want to measure it with the balloon?
Would people IVUS now after the dissection, or just go ahead with the stent?
Well, we don't use IVUS so frequently, but I think I would cover a 24 minimum, so you're okay to just go ahead and stent it.
24 balloon. Do you think it will take 3.5 or 3 stent? What is your
right, we had sort of discussed 3.5.
3.5?
It should be a 3.5.
Yeah, I think this is a big LAD, so I think a 3.5. I wouldn't take it to very high pressures, but I would implant it to 3.5.
I'm just a little concerned. Distally, the vessel looks really definitely big, but what about the proximal LAD? Is that 3.5?
Yeah, well, I think where they're doing online QC, I think where they're measuring, and that portion of the LAD, I think it is 3.5.
All right.
So what's the ultimate...
24 balloon.
Balloon, huh?
Oh, you want to take a balloon? I'm sorry. Okay, no, don't open the stent. You want to take another balloon?
No, just measure it with the balloon. Speak with definite of balloon. No, it's not required.
You want to measure the length with the balloon, or go ahead with the stent?
Go ahead with the stent.
Yeah, I think...
This is a 3.5/24 Resolute.
Okay, we'll take that Resolute there, 3.5/24.
What you have noticed, Marty, is the QCA gives reasonably okay for lengths of the vessel, but the diameter always underestimates what you think.
So shoulder to shoulder, what length do you get with the QCA here?
22.
22. So I think, I think 24 probably is a good, I think the Resolute's a good choice for bifurcations. If you have to cross through the Resolute, it has a fairly open design, and also the struts on the Resolute are edgeless because it's a wire design, so there's not so much friction from stent to stent. But there are many stents that are very good in bifurcations.
So what strategy you use when you have a side wire in? Up to what pressure you would dilate the main vessel and take this wire out and then rewire? Would you go initially high pressure, or you will go... I tend to go around 10 or 8 atmosphere, then come out.
For the side branch, certainly I wouldn't go more than 8 or 10.
Yeah.
I think one of the questions was how high would you deploy the stent? Would you deploy it full before with the wire in the diag?
I never worry about trapping the wires. I think it's very easy to be able to. So by full pressure, I generally would go. In this case, maybe 12.
Okay.
Because I think the 3.5 is true sized. I don't want to push it too much. But I think the 24 is a good length here.
Go millimeter down.
It's pretty good. Maybe back a hair.
And here's the guide of it.
Yeah, just be careful, because the proximal LAD may have some remodeling.
Can you see the epicaudal ones to see the proximal?
And you're not seeing it here.
Actually, the proximal landing needs to be defined carefully.
Yeah, we'll see that again. We'll see that again in the epicaudal one.
Yeah, I think I'd look at a different view to be able to see exactly where that's landing. Because I don't mind landing a little bit further distally.
Not bad.
It's not bad yet.
Yeah.
It's okay.
Yeah, it should be okay.
Okay. We'll come back a minute. That's okay.
Yeah, I think that looks fine.
Yeah, finally we go to the RAO cranial ones. The original view.
Don't be careful. Got the oxygen there.
Okay. Same view. RAO 41 cranial, whatever you have taken there. We always prefer checking once in the same view which we did before, so that it gives exact idea. I think that's okay.
I think it's going to be fine.
Okay, go ahead.
So this is a 3,524, which will take to 10, 12 atmospheres.
Yeah.
12.
That's enough.
Put a 3. Go higher pressure.
Yeah. Looks a lot bigger now.
Too big.
I think it'll be fine.
I think it's fine.
The cone angles on the Resolute are very tight, so you don't get, at least I think you get
So
fewer
what
edge
pressure is
dissections.
that? What
That's,
pressure is
that's
that?
12 atmospheres, 10, 12.
Show the wire. Some ectopic, distally. Deflate.
So,
To the tip.
No pochinda. Abhi kam ho raha.
He had some discomfort during that inflation.
Abhi theek hai? Show the tip of the wire.
That's okay.
That is deep inside. Abhi theek ho jayega. Give some NTG.
Come out here.
Wires are falling.
Diagonal will be issue. Looks diseased and narrow proximal.
Just watch your guide in the left main.
I think the guide is out.
Because we're working on the bifurcation, unlike a routine usual, we take about 6 French through radial. But this patient was a fairly big-sized person. We did ultrasound of radial, and we did a 7 French guide in the radial. That's how we are able to do the procedure comfortably, even though you have 2 wires and things.
Well, with 6 French and a 3 or a 3.5 stent with a side branch kissing, it's very tough. It makes it very, very uncomfortable to push things in,
Take a picture.
especially with the radial 6.
So guide has slipped out just a little bit.
Adhi ko chodo, udhar dekho thoda. Okay. Distally it's fine. Apical.
It's very nice.
That's fine. What do you think about the result?
Yes.
Apical.
Well, the flow is good, but obviously it doesn't look very pretty.
Epicranial. As long as you're able to maintain a TME3 flow with minimal residual disease, we all data now to show that maybe single stent is always preferable, but it looks like unless there is a dissection or something.
There's a little dissection at the ostium of that diag now.
Yeah, I mean certainly in this AP cranial view, the ostium of the diag does not look good. So I think you have to rewire now through the stent, and you'll have to dilate it and then see if you're going to be able to treat this without a stent.
No, you have to end up with kissing in this patient for sure, at least to the diagonal ostium.
So would you pull this wire, or are you concerned about that dissection? Would you take
I would not
LED
pull the wire. I would do the LAD wire or a third wire. Yeah, I would not lose wire support here. Because I do think there's a true dissection at the origin of that diag, so I would leave that wire in, as you wire.
Yeah, I think that the expression here is that we need to put the wire, leave the wire in, try another wire.
Okay, third wire.
Now, some people like using the LAD wire, which I think is fine. I think we're not worried about the LAD, but I certainly would not pull the diagonal wire at this point. I mean, there's good flow, but I think you're right. It doesn't look pretty, and in the cranial view, I think the ostium is dissected. Now, whether that was from the pre-dilatation or not, I can't say. But this is exactly the point the French make, which is when you pre-dilate, you end up getting dissections, in which case you end up with more stents.
Now, most of these dissections appear to start when you dilated the LAD, though, and that might have extended.
In this case, you're right. I can't say what caused it.
So without losing access, we are taking another third wire. We will try to go through. We gave a little bigger curve so that it doesn't go onto us.
What's the risk of pulling the LED wire, because that LED is very nice now? So
I don't think there's any risk. I think you could do it that way for sure.
Just pull it out and exchange.
Just test.
In terms of wire choices when recrossing, if you have difficulty, what are people's thoughts about changing wires?
You know, I think everybody has their favorite wire. I still think the BMW is a good crossing wire in this scenario. I think that the Pro Water is another good wire. Some people like the run through. And then, you know, if you have difficulty with the workhorse wires, I think some people would go to a hydrophilic wire.
Yeah. Sometimes when you find difficult, we take
the problem with the hydrophilic in this case is you have a little dissection to start with,
right.
And I think you're more prone to get into that dissection and to extend it with a hydrophilic wire. So I would prefer not to use it if I could.
Prior to the stent placement, the LA caudal really laid this bifurcation out the best, but now the anatomy and orientation can be changed, and sometimes that's what challenges.
Well, the wire itself does,
yes.
But yeah. I think you get some straightening and flattening.
I think this is showing the...
I'm seeing some contrast retention in that proximal LAD that has me nervous.
Yeah,
that so I think that there's a proximal edge dissection associated with the LAD, so just be aware of that, everybody.
This might be reasonable to IVUS at this point to try and figure out what's going on. Maybe can we open the IVUS catheter? Can we set up the IVUS?
Bigger size and interesting.
So the strategy of keeping the LED wire here was a reasonable strategy.
And the Stent probably is slightly bigger
yes.
than, maybe you would have 3.0 would have been better.
Yeah, that's what I thought. It must be a 3 possibly because the 3.5.
So now you're making a good case, but there should have been a 3.0 instead of a 3.5.
I may have to extend it now.
Now we'll remove the diagonal.
Do you want to go ahead and IVUS first, the LAD, see what's going on, and then?
Yeah.
I mean, that's always a debate as well, because you want to
caudal or an
remove the other diagonal wire.
Yeah.
Yeah, I think you can move the third wire, the trapped wire in the diagonal.
Yeah, that's what it is.
Yeah, I would fix the LAD first.
Yeah.
Yeah, and I think you have to decide if this is just an edge dissection from the stent or is it a subintimal hematoma. I think because you treat them a little differently. So in this case, at least my preference would be to look at it by IVUS.
IVUS, yeah.
The issue, though, is if you're going to fix the LED, now you're going to have to pull out this diag wire, right? So if things are stable, would you consider doing anything with the diag, or you say, you know what, leave the diags open?
If things are stable, and if I see by IVUS that it's something I can easily control, then maybe it is a good idea to fix the diag, because you're going to have to pull the diag wire.
I think this LED is increasing.
So we'll see the LED in some caudal view, AP caudal, RAO caudal. Shall we?
It's right at the edge. You can see it pretty clearly.
The edge.
We're going to go to the caudal here.
I think the LAO or AP caudal will show it well. We just want to make sure we control this so you don't get retrograde dissection back close to the left main.
Yeah.
Yeah, I think so. I think I would stent this right now because it's a circumferential dissection. It's on both sides of the artery, so you want to control that.
So what size you would use now?
Scene plus first one.
What's happening to the... And would you wire the circumflex now that there is some disease of the circumflex ostium because you're going to be...
There is a little disease in the circumflex ostium. It's not significant, but there is a little disease.
Yeah.
I mean, the patient is stable. I don't know how quickly it takes you to do IVUS, but if...
We can do it right away.
I mean, I like using IVUS to make the decision to answer your question about how large of a stent and how long of a stent to put in.
And would you reach the ostium, or will be fall short of ostium of the LAD because this?
Exactly, yes. Yeah. It's a fairly shallow takeoff of the circumflex. If there's any evidence that you're going to go close to the origin of the LAD, I agree with you. I'd probably have a second protective wire in the circumflex too.
So we're making the case complicated.
The case has already become complicated. We have dissection of the ostium of the side branch, and we have a proximal edge dissection in the LAD. So, but we'll fix it.
That's how it happens in the live cases.
Yeah.
Getting pain.
It's always a good idea to keep an eye on this intermittently just to make sure. There are two philosophies. Some people say if you inject more, you make the dissection worse. So I think it's good to keep an eye on it, but not to inject forcefully and not to inject too much.
So what about putting a 3 and
I am thinking as well that in this case we likely will go to a 3. Because the 3.5 caused an edge.
And at the overlap you go high pressure, but don't go high pressure, the ostium.
Exactly, yeah.
What wire are you going to be putting that stent on? Were you going to use the side branch wire and pull back the main branch wire? Because you don't want to trap the side branch wire all the way with another stent.
It's very, this case is good.
Well, you know, it's an interesting point. I think that you could implant this on the diagonal wire.
That's correct.
Okay, and then you've got the diagonal wired, and then you can rewire the LED.
Yeah.
So that would, to me, be the better approach here. That would be a slightly more elegant solution, yes. Because wiring the LED will be easy, wiring the diag is less easy.
Can you show the tip of the wire of LED? Where it is gone to? So we'll go beyond the stent?
Yeah, I think you can quickly check the stent just to see that.
Yeah.
So you have excellent expansion of the stent. You can check the distal edge.
Go a little bit further,
Just
maybe?
a tiny bit further. I don't know if they can see the IVUS at all.
Can you turn just the camera onto the IVUS, please? Show the IVUS image.
Can you show the IVUS, please?
So you're within the stent. Okay. Okay.
Go, you want to go beyond it? Okay, that's fine. Yeah.
That's fine. So you see, it's obviously very well expanded.
Yeah, now we can see it.
Circular. So you're pulling back manually or mechanical? Yeah. Okay. Is it coming back?
Yeah. Is it pulling?
Okay.
Yeah. Can you fluoro for a second? See where we are? Okay.
It's got a long way to go.
Does it come?
Is it moving or no? Let me see.
It's not moving?
Just
I think you probably can do it manual.
Yeah,
it's not really moving.
I don't think it's coming back.
Yeah, yeah, well.
Is it okay?
Okay, yeah, that's fine. That's fine. That's good. If you.
There it is.
We
right
lost
there.
All right, so there was a dissection. Okay.
Can we see the IVUS again?
Yeah.
Yeah, I think what you want to do is to
slow.
look at the proximal
Yeah,
edge.
go in, go
see if you can
slowly,
find the proximal edge. It's a pretty severe dissection.
You want me to go again?
Yeah, go back.
Interesting.
Yeah. No.
I'd stop at the ostium of the LED, make sure the ostium is clear.
Go a little bit further.
So I don't know. Yeah, okay.
A little bit more.
Yeah. Shall I come back?
No,
No, just go antegrade.
Yeah.
Okay, you're already in the stent.
Okay, now come back slowly, please.
And if you can stop just at the edge.
Yeah.
Right
That's
there.
where, that's where.
Right there, you see it?
So a lot of
Come
plaque
back
mass.
slowly
So
now.
look how large this vessel is.
Yeah.
So it goes back to the ostium of the LED. So in terms of that discussion, I think I would put the wire in the circ.
So can you just stop at the ostium? I'd like to see if there's really dissection at the ostium. There's a lot of plaque burden in this LED. The actual size of the LED is large. I think the problem was not so much 3.5 was oversized, but there's a lot of plaque. And when you land a stent into an area of significant plaque, you get a lot of edge dissections.
That's true. So the cause of the dissection is that you stented a large stent in a plaqued vessel.
Yeah. So this makes the case for having done IVUS in the beginning. It might have changed our strategy a little bit.
Yeah.
So I think at this point, I would pull the diag wire, put it in the circ, and treat the proximal LED.
That's correct. Pull the LED wire into the circ.
So one of the thoughts is to do the proximal LED over the diag wire.
And jail it the whole length? Or?
You actually can pull the diagonal LED wire out.
Okay, so you can keep that diag wire in, and then you'll pull the LED wire out and put that in the circ. So you don't have to rewire the diagonal branch,
Oh, I see
is what I'm saying.
Okay, okay.
Which is actually nice.
Right, so yeah, that's right. That's a good idea. So why don't we pull the LED wire and go into the circ with that? No, but the distal LED is fine. It's really just proximal is what Marty's point is.
We can put another
No, we're going to have to stent the proximal LED. So you can't put a third wire, and you can't stent over that diag. So leave the diag wire in, pull the LED, and put it in the circ.
I mean, you can trap the LED wire, but I'm not sure you need the LED wire, frankly.
So the discussion which is going on here is that you will keep the diagonal wire in, pull the LED wire out, put the
LED in the circumflex to protect the circumflex, and then treat over the diagonal wire the proximal LED.
That's right.
And then certainly as you finish working on the diagonal branch, you can rewire the main LED.
So,
okay. So why don't we do that? Put the LED wire back and put it in the circ.
of the circumflex now getting compromised. Is that right?
Yeah, there is some.
I think that certainly is a concern.
We'll put another wire.
No, but you're going to have to remove one of those two
See, you
wires.
don't want to trap the wire,
proximal vessel.
Srinivas, so I think it's better you pull the LED wire out.
Yeah. So we're saying take the LED and put that into the circ.
Yeah.
You still have the proximal LED protected.
Yeah. Abhi theek hota.
Now, what size and length stent do you think we need here?
That's difficult.
I'm not opposed to the idea of putting in a 3.0, undersizing it slightly. And then if we need a larger post-dilatation balloon, I think so. Let's look at it again. It's a little foreshortened in this caudal view, but I think it will.
18? 15?
15 maybe? 18? Don't know, 15?
Well, I think 18 is too long.
18. Yeah, 12 or 15 is what I was thinking.
Yeah, maybe 15.
15.
Maybe 15, a 3.0 15.
I mean, one of the downsides of the thing is you just got to make sure that you're not going to get into the diag with this stent because you're in the diag.
But you're way back, don't you think? You know, the plan is not to take this stent close to the diag.
But you know, looking at it now, your initial thoughts of 12 may be right, though. What do you think? Let's take a quick picture here.
Yeah, why don't you take another shot and we can decide. This is turning out to be a very interesting case. I'm sure Srinivas doesn't agree. It presents some of the interesting issues.
Great case.
I think a 12 may be enough. What do you think?
I just want to see where the diag comes off. I think you could use a 12 or a 15. It doesn't matter to me.
15 is safer.
I think a 15 is safer.
3.0 15
yeah.
endeavor, I believe.
So just a 3.0 15.
Because of the straightening right now. Suck may look a little bad. The dissection is already extended proximally.
Yeah, I'm watching that very closely, I see.
No, I don't think so. It's not on IVUS because it's a funny angle here. So on IVUS, you see that the ostium is okay.
Fix both the wires.
You should rock it there.
Test.
We just want to make sure that we're avoiding the ostium of the diag here.
Okay.
And I tell you, 15 looks too long.
Yeah.
You can take 12?
Yeah, let's take a 12.
Yeah, it looks too long.
Is there any other view which separates this vessel better from circumflex and LED?
This is an LAO caudal view. I think you see it. I think the caudal views are going to be the views that help us most. You could look at AP caudal as well, but this view I think separates them pretty nicely. So,
okay.
We have a 3012?
Yep.
Great.
His hemodynamics are stable here.
I think the patient is doing okay. He's, you know, he's not tachycardic and his blood pressure is fine. Although I will say it's an impressive dissection.
Yeah. Instructive.
This is the shortest anyway we have.
That'll be fine. I think you need to get you can go a little further in.
I just want to make yeah, a little bit.
Right
just test here.
Got to go in a little bit more tight. That's the edge of the stent. Then we'll go to the other view and see the proximal stent. you're just barely in the stent there, which is good. And proximal, you look okay.
Which is pretty much what you want. Yeah.
You need to go in a hair, maybe, but. No. Go LAO caudal again, please.
You have to go LAO caudal.
Yeah, let's go real.
Yeah, I would go caudal. I think you're right. Maybe a millimeter or so further in. Yeah.
You can go a little more LAO. More LAO.
Yeah, that's what we're doing here.
Yeah, this is pretty steep LAO right now.
I think it's fine.
That's not bad.
I think I like it.
That's good
fine.
Yes.
I think it's
okay. That's good. Okay.
Let's go.
Yeah.
Don't go too high here.
Here, I think
that's a 3/0. We're undersized.
This is a 3/0, so we're nicely undersized.
12.
Okay.
Okay.
Deflate. We'll go to the overlap segment and give a high pressure.
You can't go too far because you have a
Watch the diagonal ostium. Don't go too far.
Yeah. So remember,
wire and then.
So now we have that third wire. We can put it.
Just want to make sure that we've taken care of this dissection. That's the most important thing. It's in a critical area. It's looking good.
So it looks good now. Yeah.
Can we have a nice shot? We can see.
Now we're going to have a good injection.
We're going to show you in just 1 second. Yes.
Use some antigen.
Sometimes you still see some trapped contrast in the subintimal layers where the dissection was.
Small test. Okay. AP caudal. Hey, that's okay.
Looks like the circumflex looks okay.
Yeah. That's fine.
Turn it back on. Turn it off and turn it back on.
I think circumflex is okay.
Rewire the LED and then.
I would rewire the LED, yes. I post-dilate, and then I think it's good to look at this by IVIS just to be sure that we haven't missed anything.
I think it's okay to leave that circumflex right now and probably go back into the LED.
Actually,
the circumflex looks okay.
Yeah, I think the circumflex does look fine.
Yeah. Would you do an IVIS again to see?
Yeah.
Or I think you're across the ostium of the circumflex.
Well, we're going to rewire the LED and we'll take an IVIS and we'll get a good look at it.
Yep.
And if you post-dilate that proximal LED, I would certainly not go to the true ostium. I'd have it in a little bit.
We will dilate only at the overlap portion.
Yeah, I would do the overlap portion mainly.
Saline.
So what's your concern about the diagonal at this stage?
Well, I think there's a dissection in the diagonal. Look at it in this view.
Yeah.
So I think that the diagonal is dissected also. I think if you look carefully at this diagonal branch, the entire proximal segment is diseased. It was critical at the origin, but there was disease everywhere, and I'm not so surprised that we ended up with a dissection, even with an undersized balloon.
What is this one?
So the plan is to simply put this in the LAD.
LAO caudal.
How much time we have? This can be postponed, is it?
Push now. Push now.
I'm trying to give a little more thing so that it doesn't go through the stent struts. We give more curve, I think. This wire tends to have a little more curve. Come to cranial.
Okay, are we okay with the time, Dr. Dutt?
Small test. They can finish off that bifurcation stent lecture and come back to us.
Imaging.
2.5.
Imaging.
12, 15 balloon.
So now we simply get to dilate the overlap point in the LED?
Yeah, that's what.
You can even do that later. You can fix the diagonal first.
I don't think it matters. You could do it either way.
Small test. Ready, cutting? Where is it going? The wire is seeking a small septal, I think.
It's okay. Leave it here.
Any other view? Elevocranial? A small test. Small test. Yeah, come to AP. Again go on to septum.
It's odd that the wire is not moving more freely.
Yeah, let's go on into a small, again the same branch I think. I'll come back more. Oh, that's one, that's one. We'll leave it there. Where is it? Oh, there is some problem with the wire curve and it's curved more.
Always have to be certain that the wire, when it entered the stent, did not go underneath it and through. When you have difficulty passing the wire.
Yeah, but distally.
But it seems like that's not the case.
I think there was an overlying branch that you keep getting into here.
Yeah, yeah. I think we'll change the shape of the wire. Small test.
No, you're good. Now you're good.
No, yeah. We'll leave it there.
You can go a little further if you want. If we want to IVUS, you might want to get a little bit further.
Basically, that is seeking a small twig.
Yeah, good. You're done. Okay.
Yeah. That's fine.
Yeah. So, do we want to IVUS now, or are we going? What is our plan? We're all set here for IVUS if you want.
I feel you just overlap, do a dilatation.
I think if you already pulled the balloon to do the post-dilatation, I would do the post-dilatation at the overlap point, then look by IVUS to make sure the LED is secured.
Yeah.
Then LED secured, you can finish the diagonal.
So what balloon you have given?
I think you...
3.0 here, right?
Huh?
Do you have a 3.0? 3.5? Okay. So I wouldn't take it up too high. And you're not going to come back to the osteo LED.
No, only at the overlap portion.
Yeah, you're going to want it to be at the overlap point, and I think you can... You know, the 3.0 is protected. You've got a 3.0 stent into a 3.5 stent, so I'm not too worried.
Okay, holding all the three wires?
Yeah.
कैसे हो ठीक है दर्द कम है अभी ठीक ठीक है okay we'll go to what view epicordial the arrowcranial sure that's fine we'll make sure that we are not in the
you're nowhere near the prox LED. That's good.
Oh.
Yeah, it looks like you're over the diag.
I'd come back a little bit.
Come back?
Yeah, I think you can come back a little bit.
But proximally, we should not be coming on to the...
Okay, right there.
Huh? Like epicaudal?
Epicaudal here?
I think you can see the stent proximal, but...
Epicaudal, we'll see. Proximally, we should be within the stent. Okay.
Little test there.
That's good.
Yeah, you're clearly out of the ostium, okay? Yeah. So this will be post-dilating just the...
10 or 12 here?
Overlap point, yeah.
That's good. Okay. They come down?
Down. Ah.
How much was that?
That was 12 atmospheres at the overlap point.
Integer thing. Just the elevations is getting...
So now we'll take a quick look by IVUS, but focus on the proximal segment just to make sure that as we pull back to the left main that we've covered everything. And then we'll address the diagonal branch.
Here's IVUS.
You just want to test one. Show that last shot.
Short this one. Short this one. Short this one.
I mean, the diag is dissected, but we knew that.
Yeah? That's fine.
Okay, go ahead. Let's go with the IVUS.
Yeah.
Yeah, I'm going. Atropine you want to?
Yeah, I heard him slowing a little bit. Is he sleeping?
I'm taking the IVUS catheter inside.
I don't think you have to re-look at the entire
No,
LAD stent segment. I just, yeah, from the diag back is really what you're interested in.
Imaging on, please.
Is this okay?
A little bit further.
That's good, right there.
Okay, can you go with the camera on the IVUS, please?
Yeah, they can see the IVUS.
Manually pull back.
Okay.
Is it coming?
So go back.
No, it's coming. It's pullback's working.
So pullback is now what
Automated.
automatic. So this is fine. You see 2 layers of stents here,
There's overlap.
and it looks again circular, nice. You see there's still a lot of plaque burden. This is a large vessel. And you see,
We're in the left main here. 3 wires.
but I did not see any edge dissection. I saw maybe you had 1 or 2 stent struts that were not fully opposed, but it looked good. There's no residual dissection.
Okay.
It looks good.
Okay.
It's very common when you bring an LAD stent back to the left main, you will always see maybe 1 or 2 struts that isn't perfectly opposed, but I think it's a mistake to try to get too aggressive at that location.
Yeah.
You know, especially here, I think, sorry, I did that. I hit the mic.
IVUS wise and this thing is
I have to stop. We'll just explain the remainder of the plan, what we'll do, and I have to cut out here.
This is the second case.
Audio went away.
I think you can't hear us.
Can somebody help with the audio?
I think audio is off. I think it's out for. Yeah, I think right now what we'll do, we check the IVUS, it looks perfectly adequate, and but unfortunately we're running out of time, so what we're going to do is address the diagonal. So the next thing we'll do is we'll do kissing balloons, take a look at the diagonal. If we don't like the way it looks, less than TIMI 3 flow, or if we think the dissection is problematic, then we'll put a stent in the diagonal, probably a 2.5 stent. That is the plan.
Is that okay?
So what's the plan? Are we going with the talk? So what's the plan? Are we going with the talk, or we continue the case? Organizers?
We're going to cut.
Yeah, now we can break away from us and you can have the bifurcation stent talk by Dr. Mishra now.
Yeah.
And then we'll work on this.
All right.
Okay.
Okay.
Thank you.
All the best.
So we can call Sandeep to deliver his talk on dedicated bifurcation.
Okay, so what balloons do you want to use in the diag and the LAD?
Sorry?
What do you want to do now? You're going to do kissing balloons?
Yeah, we just to do a low pressure kissing and then watch how it is behaving. Then we decide about the second step.
Can we get Dr. Mishra's slides on, please?
Good afternoon, everybody. And as we can see, the top talk is, focused at this area only. You can see that, what kind of problems we have if we plan a provisional strategy. And once we go to 2-stent strategy, then all those, issues that we are seeing right now are, real problem. And naturally, you can see that the procedure also gets prolonged.
Please see the fluoro pictures, please. This is the stage where we have left you. There the diagonal ostium was dissected. Next. Then we did a dilatation of the diagonal ostium to just make the stent struts free. That was a balloon which we initially used to dilate, that is 212 balloon. Next. Then once we made the passage free, next we took 2.25 into 14 endeavor resolute and park the stent into the diagonal. Then next, we checked in next. Multiple views to see that not to miss out. Then next, finally we did a final kissing. Next, next, next. That's a final kissing what you are seeing there. Next, we made sure that we will not come too much proximally. That's the final result. That stent dissection of the diagonal is sealed off and the flow looks okay. Next, that's the final result. Freeze. We made sure that LCX was also all right in the caudal views, and then the cranial, the diagonal looks okay. What do you feel? Is okay?
Very good.
Okay, thank you.
I think it was a
result. He
okay,
kissed well.
Yeah.
And
thank you very much. Bye. So
No,
you can continue with your talks there.
It was
Thank you.